On behalf of the Neonatal Care Academy and the Hearing and Balance Academy, thank you for participating in our e-seminar event today, Should We Change Our Newborn Hearing Screening Protocol, with our esteemed guest speaker, Dr. Kai Oos. Dr. Oos is actually a paediatrician by background, but quite early on in her career developed an interest in paediatric audiology. She came to the UK from Estonia in 1998 as a Wellcome Trust Research Fellow to do her PhD in audiological medicine. After completing her thesis, Professor John Bamford invited her to work with him on the evaluation of the NHS Newborn Hearing Screening Protocol or programme in England. Her research interest is primarily in auditory neuropathy spectrum disorder, again, primarily in infants, but also in adult patient populations. Dr. Oos is the MANCAD teaching lead, as well as the programme director for the scientist training programme in neurosensory science and an academic lead for higher specialist scientific training in audiological science at the University of Manchester. So, Dr. Oos, I would like to hand the presentation over to you for today's session. Thank you so much.
Thank you so much, and thank you very much for inviting me. I'm really looking forward to giving this talk. It's a topic that is very dear to my heart, and the main challenge for me is to try and keep in sort of 45 minutes because, as I said, I find this topic extremely interesting, and I hope so do you. So what are we going to talk about today? I understand that there are people from all over the world with all sorts of different backgrounds, and thereby I give a little bit of an overview of congenital hearing loss, the epidemiology, the impact, a bit about screening. Then I do a hard pivot and talk about auditory neuropathy spectrum disorder. And then I will sort of try to bring it back to newborn hearing screening and think a little bit about, are we missing any cases? Does it matter? And what are the potential solutions? Just so that you know, I am definitely not going to preach at you because I understand that you all have very different contexts. And I'm not going to give you a very clear solutions here. It's really mainly to sort of reflect and muse together and make sure that we don't just take things the way they are, but we keep on questioning and challenging what we think we know. Okay, well, first of all, as I don't know you guys, and sadly I don't see you, which I really miss, but there you go. My question to you is, what is your professional background? I would like to get a little bit of an understanding who I'm talking to.
I'll launch that poll for you, Kai, so that we can see it on the screen and then everybody can answer.
Wonderful.
There we go. So what is your professional background? Is it medicine? Is it nursing? Is it audiology? Or is it something else? We can see that there are 16% of people today, 16% who are medicine, 4% who are nursing, 71% have ticked audiology, and 9% others.
Okay, that's very interesting. Then that sort of puts my next question in a slightly different context, but I will ask you anyway. So how much do you know about hearing in infants and children?
Excellent. So we'll launch that poll for you now.
Please.
So
yeah,
how much do you know about hearing in infants and children? You know everything there is to know. You know quite a lot, you know a little. or you really don't know too much about this subject. So 12% said they know everything there is to know. 65% said quite a lot, 19% said they know a little, and 3% said they really don't know too much about this subject.
Okay, that's really, really helpful. So, okay, well, thank you for that. That gave me a little bit of an understanding of who is it that I'm talking to. And I very much understand that for some people, some of it is very clear and they know it anyway. Maybe for some others, things are completely new. But I will just continue how I planned. So, congenital hearing loss. Well, we know that in high-income countries, there is approximately 1 per 1,000 babies are born with moderate or greater bilateral hearing loss. And there have been a lot of different studies about it, but this is sort of 1 in 1,000 is something that is also quite easy to remember, because I want people to have a bit of an understanding what we are talking about. It's very important to point out that it is considerably higher when mild and unilateral cases are included, and it is also considerably higher in low and middle income countries. So I have a relatively sort of random collection here of different countries, but I think it is actually a really good example to give our talk a bit of a more global feel, that when we talk about hearing loss, congenital hearing loss that is present at birth, we are talking about very different contexts all around the world. And as you see in some countries there, the prevalence is considerably higher than, for example, in Britain. So according to WHO, a disabling hearing loss is usually described as hearing loss above 30 or 40 dB HL. But we also know that this is a relatively blunt way of looking at it. When it comes to young children, even mild hearing loss can actually have quite a considerable impact on their development. So this 30 to 40 dB HL is something that we bear in mind when we talk about the sort of like a bigger picture. But I want to very much emphasize that actually in children, milder hearing losses make quite a big difference as well. Okay, now, as you all know, then hearing loss obviously is a hidden disability. And in young children, we very often don't know whether they hear or don't hear. And this is a good opportunity for me to sort of blow a Manchester trumpet a little bit, because I think it is fair to say that the first infant hearing screening does come from Manchester. In 1919, actually, the department was first founded, and it started with Irene Ewing and her husband, and they together actually in 1944 came up with this first hearing screening that is very often called Ewing hearing screening test, that actually is probably now in some countries still used as 9-month or 7 to 8 month distraction test. But originally as a screening tool, that does come from the department that I'm very proud to work at. So this is a history. And for quite a while, these different screening methods were used. And then at the end of, or sort of the beginning of 1990s, when the technology had already developed so that there was an opportunity to think about using objective tests, then of course newborn hearing screening program was first recommended. And it started in different states in the United States. In Europe, actually, the Netherlands was one of the pioneers. And in this country, in England and Wales, we started newborn hearing screening program in 2001, and by 2005, 2006, the whole of England offered new mothers newborn hearing screening opportunities for their children. And now I have some really wonderfully colorful slides. Here is one, actually, this is drawn by Adrian Davies, who was one of the main drivers behind newborn hearing screening program in England and Wales. And don't worry about all the details, but what you see here is the overall protocol for well babies, which means that there are 2 attempts with automated otoacoustic emissions. And if we don't have clear results in both ears, then there is going to be automated auditory brainstem response screen. And if the baby doesn't have a clear response in both ears, then they will be referred to audiological follow-up. Now, this is for well babies, and for babies who are at high risk, there is a slightly different approach. So all these babies will have otoacoustic emissions, automated otoacoustic emissions, and automated ABR. And we will come back to why in a moment. So that is an overall approach. Obviously, there is a lot more detail and nuance there, but this is a really important thing that I want to emphasize, that in this country, and as far as I know, in many, many other countries, in well baby populations, we have a 2-stage screen. That means that otoacoustic emissions go first, and then automated auditory brainstem response. And in high risk population, in neonatal intensive care unit, all children get also automated auditory brainstem response screen. Whether otoacoustic emissions are done or not is different in different countries. In this country they are done, in some other countries they aren't. Okay, so this has all been absolutely fantastic. And I'm the biggest advocate of newborn hearing screening program you will ever meet. The results have been absolutely fabulous. This is from our study already 15 years ago, but I've checked. The overall results are very similar. After we started newborn hearing screening program, the age at diagnosis is 10 weeks, 10 weeks, not months, 10 weeks, and age at the start of the intervention is 16 weeks. And to put it again into a better context, I want you to all remember, and some of you are, I'm very, very aware, some of you are still working in the context where there is no newborn hearing screening program. So I don't need to tell you what happens when there is no screening in place. But to sort of look back at the historical data in the United Kingdom, the mean age at suspicion of hearing loss was 19 months. The confirmation of hearing loss was 26 months. And hearing aids, the average, the mean age at giving children hearing aids was 30 months. So if you now compare these 10 weeks and 16 weeks and those 26 months and 30 months, I hope you all agree that this is really quite amazing. So that has been a big success, and whatever I'm going to say now afterwards and criticize certain things, that isn't to take away from this success that we are very proud of. And I know that we are not at all unique, because in most countries who have newborn hearing screening programs, the results are very, very similar. So let me quickly do another little poll. So Judy, if you could help me with that one.
I certainly can, thank you. So the question is, how is newborn hearing screening done in your country or region or hospital? So I'll launch that poll on the screen. 80%, 80, said they're using a combination of OAE and ABR. 12% are doing an ABR only program. 3% use other ways of identifying childhood hearing loss. 4% don't have a screening program, and 1% don't know. So mainly OAE and AABR.
Very good. Thank you so much. And it was pretty much what I sort of expected, and not only the sort of proportions of OIE and ABR only, but the other responses as well, because as I said, this is a very global audience, and I do want to acknowledge that everybody is working in very different circumstances, and I don't want to pretend that that is not the case at all. So thank you very much for these responses. Okay, so as I said, the newborn hearing screening program that we have been doing in this country has been a success. There are obviously all sorts of problems, not only the problems that I'm talking about today, but all these problems don't take away the fact that it is children are being identified much, much earlier, and obviously the outcomes are considerably better than what they used to be, 25 years ago or something like that. Okay. So this all sounds wonderful, and not that I like necessarily putting sort of negative spin on things, but I do like critical thinking, and I do like questioning what we are doing. Is that the best thing that we can do? Is there anything that we can maybe do slightly differently? And this is just a relatively sort of, I just looked at a sample of different studies, and what I like about this is that there are some European studies, there are American studies, there are Australian studies. It's quite a sort of overall picture. What we see is that obviously there are some children who are missed by the screen. There are some children that are missed by the screen because they have postnatal onset of the hearing loss, or it's a progressive hearing loss, or there are some sort of degree of configuration that makes hearing loss very difficult to identify. So there is a whole range of different reasons, and one of those studies actually, it was this, I think it was the DIDIA study from 2013, is the only one of those kind of studies that actually point out that it is also in some cases auditory neuropathy spectrum disorder that is missed, even though the percentage in this particular study was relatively small. I think it was a sort of around it was 4% of all cases that were missed. So just to summarize again, so who are missed by newborn hearing screening programs? They're those who were not screened or the screen was not completed, and that is in itself quite an important group of children. And even though we are going to focus today on auditory neuropathy spectrum disorder, I don't want to sort of be dismissive about those other groups. In very similar category, also those who were lost for follow-up. When we sort of started doing newborn hearing screening program, then I traveled a lot around the world and was talking about our program. And one thing that we always found is that in England, the lost for follow-up percentage was relatively small. So compared to many other countries, we somehow got it right. There were still some children who were lost for follow-up, but in general, it doesn't seem to be a very big problem in this country, and I'm aware that in some other countries that is actually quite a big problem. And you really don't want to lose the children who have been referred because they are much more likely to have hearing loss, and very often there may be also some additional social issues that actually these are the children who maybe need more help, not less. Then, as I said, different degrees and configurations that make hearing loss difficult to identify: progressive hearing loss, postnatal hearing loss, then false negatives like true false negatives. That's a very funny thing to say, true false negative. I don't think it's an official term, but that means that actually none of those other things were true, but there was probably some kind of a technical hitch or something like that. And then, very importantly, auditory neuropathy spectrum disorder cases, and not just that we miss them. In our particular protocol, this is an auditory dysfunction that is actually not screened in healthy baby population. Okay, so now, as I said, we are going to do a hard pivot and talk a little bit about ANSD. And before I do that, I would like to know, how much do you know about auditory neuropathy spectrum disorder? And Judy, can you help me?
I can, thank you very much. So I will launch this question on everybody's screens for them. So what do you know about auditory neuropathy spectrum disorder? 7% of people have said they're experts.
Excellent.
55% have said they've got some experience. 30% have heard of it, and 8% have never heard of auditory neuropathy spectrum disorder.
Okay, excellent. So a nice mixed group. I'm obviously going to be annoyingly patronizing for the people who are experts, but bear with me. So very quickly, this auditory neuropathy spectrum disorder, this term was coined in 2008 in Como. I was very privileged to actually be part of this panel of experts. It's not an ideal name because we know that it isn't really auditory neuropathy in all cases, because it can also affect, for example, inner hair cells. But the other part of the term spectrum disorder is really absolutely accurate, because it really is a proper spectrum disorder. So for those who don't know, this condition is characterized by ABR that is absent or severely abnormal at high levels, and otoacoustic emissions are present. Sometimes they can disappear, but then cochlear microphonic is present. So what it means, very simply, is that outer hair cells, which in most cases are damaged or absent in childhood hearing losses. That's why we try to screen for them using otoacoustic emissions, because otoacoustic emissions are actually specifically going to give us information about the health of outer hair cells. So in auditory neuropathy spectrum disorder, outer hair cells are functioning normally, and the lesion is either in inner hair cells, in synapse, in auditory nerve, or even in the basal ganglia. So that is the important thing. So by definition, we can't screen or test that by using we can test because that is part of the test, but for screening, otoacoustic emissions are not going to pick up these cases. So that is the main core of today's talk, actually. So very briefly, there is, as I said, in some cases, the ABR can be completely absent. In others, it's severely abnormal. Sometimes it can also be temperature sensitive, but let's sort of not discuss that unless people have questions about that. The hearing threshold can be anything from near normal to really profound hearing loss. And the most important part of this presentation is that there tends to be a real mismatch between hearing threshold, the pure tone audiogram, and the speech perception ability. So in general, speech perception is considerably worse than what one could predict from a pure tone audiogram. Now, a very interesting part of ANSD is prognosis, and that is especially important in the context of newborn hearing screening program, because what could easily happen is that you are sitting there with a family whose baby has just been diagnosed with auditory neuropathy spectrum disorder at birth. And unless we have some extra information, all we know at this stage is this baby has normal otoacoustic emissions. So it means that their outer hair cells are working, dancing beautifully, and they have absent of very, very abnormal ABR. But what the parents ask you, because they are not that interested in OIEs and ABRs, let's be honest about that, what they actually ask you is, what does it mean for your baby? What does it mean for our baby? And the only really truthful answer at this stage, unless you know something else, and in a moment you will hear what those something else can be, but unless you know something about the genetics or whatever, the really truthful answer at this stage is we don't know. Because this child, this little baby, can end up having normal, or I would say near normal auditory function, and the baby can also have total lack of sound awareness. And I will give you, and everything in between. And I will give you two examples just to sort of illustrate my point here. And that is, for example, parents very often call me and ask me about all sorts of things about auditory neuropathy spectrum disorder. And I have this one really lovely family. Their child is doing very, very well, has near normal hearing thresholds. But the mother called me the other day and said, my child has real problem with French. And I thought, and please don't worry, I did not say to the mother, I'm not a monster. But this thought went into my mind, through my mind, and I was thinking, well, that's not so bad, that's quite lucky. And the moment I had thought about it, I thought, shame on you. I mean, I am very lucky to actually speak quite a lot of languages, and this has enriched my life a lot. So for me to even think about a child like that is completely wrong. So I was wrong. But I just want to emphasize that on this really sort of normal or near normal spectrum, there can be children who otherwise function really, really well, but may have problems with, as I said, with foreign languages, in noise, and so on. So that is one end of the spectrum. The other end of the spectrum is, for example, there was, when they only just started doing cochlear implants in ANSD, then at first they did all these children who were, likely to be high achievers and everything went very well. But then when there was quite a bit of success, they also started to do cochlear implantation in children who were very disabled. And I remember this one child who was he had all sorts of other medical and developmental needs. But after the baby had got cochlear implant, he started to smile. So there was no other improvement, if you like, but the baby started to smile. And now if you think of the family, what a big change it is, actually. So I want to give you these examples, these two extremes, just to really give you a little bit of a feel of what is it what we are talking about when we talk about spectrum disorder, and what is it what we are talking about when we try to predict what the prognosis is, because it can really be a sort of a very, very wide range of different outcomes. Okay, so management, very, very briefly, in some cases there is spontaneous recovery, but also in some children amplification is useful, other assistive listening devices, FM systems, for example. Auditory implants have been very successful in many children, and it is much more widely used than it used to be many years ago. And of course, in some cases, either the families choose to use visual communication, or actually because of the auditory abilities, the visual communication really is the only way forward, because sadly not in all children cochlear implants don't work for all children with ANSD. We may come back to that if you're interested. Okay, so now we are getting closer to what we want to sort of emphasize here is the epidemiology and etiology. I see that time has gone is going on, so I try to be really rather quick here. So in general, I would say that 10% of all children in permanent childhood hearing loss population have auditory dysfunction, have auditory test results that are consistent with auditory neuropathy spectrum disorder. I think that's a fair comment to make. We know that it's a very common, obviously, in at-risk population, where the etiology is very often linked to prematurity, low birth weight, sepsis, ototoxic exposure. Hyperbilirubinemia is thought to be the most common cause for auditory neuropathy spectrum disorder in this population, but hypoxia also plays a role. So these are the etiological factors that we usually see in at-risk population. And remember, in England and in many of your countries, regions, or hospitals that you work at, this is the only population that we actually actively screen for auditory neuropathy spectrum disorder. So obviously the different epidemiological studies are give us slightly different results depending on what is the underlying population and so on. But from our study and from the Australian study by Gary Rance, approximately 0.2% of all babies in neonatal intensive care unit have auditory neuropathy spectrum disorder. I think that's a sort of overall accepted figure. Okay, so this is all in at-risk population in neonatal intensive care unit that we, and in many other countries, the protocols are such that we actually actively look for ANSD in these populations by using auditory brainstem response screening test. Okay, so let's put that all aside. We don't have much to sort of worry about that at this stage. But now the question is, and that's a really good question. So what's the prevalence in well baby population? And I hope you're all sitting comfortably, because this is absolutely vertigo inducing, because if you look at the different studies, you get results that are absolutely all over the place. The first one is a Colorado study, and this is from their newborn hearing screening program. When they first started, they only used ABR, auditory brainstem response, and they found 1 in 500,000 the prevalence in well baby population. And I hope that you all agree that if that is the case, then that is very low, and we can almost say that this is not even worth talking about. Well, that sounds a little bit maybe inappropriate, but that is so low that from the epidemiological point of view, that is not a big issue. I remember I once gave a talk, and I was talking about this and saying in a very like, I'm this expert of that, and that the prevalence in well baby population is very low. And there was actually a parent in the audience who had 2 children in his family who both had ANSD, and both were from healthy baby population. I know this family very well, and their father said quite loud, "Not in my family." And that actually is very sobering, because it's one thing is to look at the epidemiological data, and the other thing is actually to sit face to face with the parents who have children with ANSD, that actually our screening program has failed for all intents and purposes. So I'm very aware of the time. So instead of going through all these studies one by one, what I would like to say, that looking at these different studies, that the prevalence figures from different studies are, as I said, very confusing indeed, from 0.3 per 1,000, which I hope you all agree is very high, to what I showed you earlier, 1 in 500,000. So, and that is to just emphasize that at this moment, the evidence is really poor for us to actually say, well, what is the prevalence such that we should be changing the protocol? Right now, we don't have strong enough evidence to actually suggest that. Is there any other way that we can look at it? Because if we miss babies, maybe understanding the etiology would help us. Let's see what we know about that. If we look at the etiology in well baby population for ANSD, the most, well, I wouldn't be so bold to say the most common one, because every study that you look at is looking at things at a different angle. And as I said, the evidence, the overall level of evidence and the quality of those studies is relatively low, not because people have done a bad job, but mainly because this is a rare condition and it's quite difficult to study. So genetic variation is one of the important etiological factors for ANSD in well baby population. The most common genetic variation that I would all like you to remember is otoferlin. The other important ones are also betrachin. That is actually the only gene that I am aware of, the gene mutation that I'm aware of, that actually causes isolated auditory nerve lesion. Then the other one is the diaphanous 3, that is a non-syndromic ANSD, and it's a dominant one. So that means that the parent, if there is a case, then a parent would also have that. At least one parent would have the same condition. And then there are others. Interestingly, connexin 26, which is the most common reason for any hearing loss, can also in some cases cause ANSD. And very importantly, also this mitochondrial genetic mutation that is linked to aminoglycoside susceptibility for ototoxic lesion. So this is really important to think about from the point of view of prevention of hearing loss. Now, very importantly, in well baby population, ANSD can also be caused by cochlear nerve deficiency, tumor or cyst. In some cases, also asymptomatic CMV. There's an interesting, relatively recent study from Italy that looks at that. I personally see there are some methodological problems because the way they define ANSD is a little bit different from what I would define an ANSD, but it's nevertheless an interesting study. And then in some cases, it can also be due to maturational delay. And these are the cases that actually recover really relatively well. Okay, so what is the way forward then? The main reason why I think I was asked to give this talk is that we need to think about whether we can and or want to change the newborn hearing screening protocols, whether there is it's a good reason to move to ABR only protocols. And even though we have looked at it in the past, it is absolutely worth looking at it now, and it is absolutely worth looking at it in the future for two reasons. First of all, we know more about ANSD now than we did even 10 years ago. So we may be what we didn't even conceptualize as ANSD, we now do. For example, these cases of cochlear nerve deficiency and different, for example, tumors and so on. And also when it comes to costs, these things also change. The equipment costs change. In general, screening equipment has become much more affordable in many cases. So even though in the past we have looked at the cost effectiveness and concluded that it is not cost effective to change the protocols, it's worth looking at it now. And this is one of the sort of latest recent studies from, it's actually an international study and they modeled it on Albania, which is actually a very good idea because Albania is a middle-income country and doesn't only give us the perspective of the high-income countries, as a lot of studies do, which I think is not really appropriate. But you will see here quite clearly, I hope, that at the moment it is still very obvious that ABR only screening protocol is considerably more expensive, and therefore the cost effectiveness at the moment is lower than the combined approach. And what I would like to very much emphasize is that just because it is like that now, it doesn't mean that this will not change in the future. So I hope that we will review it in a few years' time again. So what are the changes that we could think of? I think what you always need to what you need to review is cost effectiveness and keep reviewing it. It's not just the equipment that we have to worry about, it's also mainly the workforce. So that is something that needs to be considered. Is it okay to just continue as is? I would say maybe not completely. What are the other things that can be done in different contexts is, well, overall sort of awareness and self-efficacy and different apps that are being used more and more in this country, and I'm pretty sure it's the case in many other countries as well. There has been quite a lot of talk about whether we should review bringing back 8 months screen, at least for children of certain risk groups. More importantly, in England and Wales, school entry screen has been decommissioned. And my question to all of you is that right? Is that sort of helpful? And I would say no. I personally am quite unhappy about seeing school entry screen go. And maybe even more importantly, we should think about different follow-up protocols. One of the things that I would say to everyone is that at least if you don't change the newborn hearing screening protocol, what I would suggest is that at least all children who are referred to the audiological follow-up should get a full assessment, including both otoacoustic emissions and ABR. I'm saying it because I'm very aware that it isn't the case in many areas. And last but not least, and maybe a little bit provocative, is genetic screen. I know that this is done in some parts of the world, and this may be the future. I'm also very aware that there are some ethical issues around that. I'm very concerned about the acceptability for their families. But why I'm putting that forward here is that if it is the genetic screen is part of the comprehensive newborn hearing screen that includes the methods that we've been using so far, and genetic and cytomegalovirus testing. And cytomegalovirus can also be obviously tested using genetic methods. Then actually we will find a lot of late onset progressive deafness cases. We will definitely find that healthy babies with otoferlin mutation and the other mutations that I was talking about. We would also provide etiological information for different medical prognosis in syndromes. Very importantly, it would also help us provide information with regard to pharmacogenetics, the example that I brought to you about the susceptibility against aminoglycosides, and it could also potentially decrease the number of children lost to follow-up. So I think all of those different options have their advantages and disadvantages, but what my main message of my talk is that we shouldn't be a sort of one-trick pony. We should really think about it, the newborn hearing screening and the wider context, and make sure that it is not just a one-off exercise, that there is a support and follow-up, and very importantly, promoting self-efficacy in the families. I'm very aware of the time, so I better draw it to the end and see whether we have any questions at all.
Thank you so much, Dr. Us, for an excellent presentation and for sharing your expertise. That was really enlightening. Thank you. We do have some questions. If you've got babies, or I say, unless we test all well babies with AABR, we will not have true data of how many well babies actually have ANSD, correct?
Yeah, and that is why it's really important to look at the countries that have already been doing screening with AABR from the very start, and that was the Colorado study that actually showed 1 in 500,000, which I mean, this is real data from their study. It is actually a published data, and also from the Netherlands, so and from Australia. So we don't have to invent the wheel here. It's important to look at those populations. On the other hand, it's also important to acknowledge that in different countries we can have different prevalences because of those genetic differences. I mentioned earlier, we know from the genetic studies that the otoferlin seems to be more common in many Spanish language countries, both in Europe and in South America. So it's very important to look at the data that we have, but also be critical about it and not think that that is the full story.
Yeah, absolutely. In fact, we have a colleague, an audiologist colleague of ours, Dr. Mary Ormson, and she will always tell the story of when they changed their hearing screening protocol to an AABR only protocol. On the first day, they picked up a baby with ANSD.
I'm not surprised at all. I'm not surprised at all.
Yeah. Okay, Miguel.
But the important thing, what I want to just quickly say is that, especially as I know this family who has 2 children, and I get along very well with this family. So from the emotive point of view, I would be the first one to change it tomorrow. But sadly or not sadly, we can't make these kind of decisions based on just emotions. It has to be evidence-based.
Absolutely. Okay, Miguel, next question from you, please.
Thank you, Doctor. It's really interesting. This is a really interesting question. Have you come across any NSD cases where the cochlear microphonics, in this case, is absent in the presence of OAEs?
Okay. I mean, if I sit here and say it can never happen, then we know that tomorrow somebody will find a case like that. So I'm not that arrogant to say that. But if we think about the sort of physiology there, then the likelihood is that, to put it very, very simply, otoacoustic emissions are a more sensitive test. You won't have otoacoustic emissions if the outer hair cells are there, but are a little bit unhealthy. But you will still get the CM, the cochlear microphonic. However, it's very important that we don't misdiagnose by actually doing the cochlear microphonic with too loud signal, because at least one of the suggestions is, and please take that with a pinch of salt, but one of the suggestions is that if you put the stimulus is too loud, that actually inner hair cells can also contribute to the results. So I think it's very important to make sure that you get your stimulus right. But if we're sort of looking at, can there be real cochlear can real cochlear microphonic disappear and otoacoustic emission persist, then I would say not really.
Do you have an indication why and when OAEs might disappear in ANSD cases? And can you speak more about spontaneous recovery and ANSD?
Yeah, oh, that's my favorite topic. How long do you have? So first of all, the why OAEs disappear? That's a very a good question. And again, I'm not saying that I know the whole story. I don't know. I don't think anybody does. But in the beginning, there was very much a suggestion that, oh, these children sometimes got hearing aids, and they just there was a sort of noise-induced outer hair cell damage. The evidence doesn't really back it up. There are some children who simply will lose otoacoustic emissions, and this is mainly because ANSD is a spectrum disorder. It isn't like a specific disease. So we get all sorts of different combinations of hearing problems, and it just so happens that sometimes, let's say, the inner hair cells are absent, and then the outer hair cells may be there, but they are not fully functioning, and that is when we actually lose otoacoustic emissions. The interesting thing is, I recently, my MSc student did a study on older people, because we know that otoacoustic emissions just disappear in older people, but nobody had really bothered to look at what happens with the cochlear microphonic with older people. And we did that. And the interesting thing is that the older people who had lost their otoacoustic emissions still had their CM quite nicely intact. So it just goes to show that otoacoustic emissions is a very sensitive test, and is not only telling us a story about whether outer hair cells are there or not, it actually tells us a story about their health. So if they are not in best health, they will disappear. Now, the spontaneous recovery is really interesting. I actually have written a whole paper on that, because it's a real mystery. If you look at the studies, then the sort of again, the percentages that you get are something from like, well, it hardly ever happens, up to, I don't know, 78% or something crazy like that. So it's obvious that sometimes there may be diagnostic problems, and actually we'd never had an ANSD in the first place. So we again have to be very critical about that. From my perspective, I would say that approximately 20 to 25% of most populations, when you look at ANSD in very young babies, approximately 20 to 25% of those recover. Not always fully recover. As I said, some of them will still have problems with their hearing in noise and so on. So we have to be a little bit careful what we call recovery, but they will improve quite considerably. The most common group that tends to become better are the babies who are teeny weeny when they are born and too small for their gestational age. So it's not just prematurity, because if everything develops typically and then suddenly there is a premature birth, that's a very different situation from when the baby is, let's say, term, but there has been something that has been bothering this fetus, and they just they are very, very small. So very often it is, for example, if there is placental insufficiency or something that is going on during the pregnancy, that is very often the reason why babies have neuromaturational delay. And these babies are, I would say, the most likely to actually recover. Not they are not the only group, but this is where I always, when somebody is very small for their gestational age, I would say that is very, very likely.
There's a really interesting question, and you talk about it a little bit before in this interaction, but it's in Spanish, and they asking about the neuropathy spectrum disorder can be diagnosed and in the long term, in by the end of life, so you can get it in different stages in life, or not.
Yeah, that is very good that you said that, because I've noticed with my own students, because I teach pediatric audiology, we once had an exam, and we had an exam question for a student that was an auditory neuropathy in an adult, and the student was thinking and thinking, and then said, if it was a baby, then I would know what it is. And I was like, okay, the students are thinking of my enthusiastic face and think pediatric audiology, and then now I always make a point that actually it was first discovered in adults, and mainly in adults with all sorts of different neurodegenerative disease. And I have been very lucky to actually work with Ataxia UK, because in Friedreich's ataxia is one of the most common neurodegenerative diseases where auditory neuropathy is seen as part of the clinical picture. So yes, this can happen in, as I said, different different neurodegenerative diseases, but even with things like diabetes, HIV infection, different viral infections. Even before all this different, all this pandemic started, actually, coronavirus was mentioned as one of the reasons that can cause something called Guillain-Barré disease. And we thought, oh, are we going to see a lot of auditory neuropathy? We haven't. That's I just make a point here.
That's good to know, because that was actually another question in the question box.
Oh, there you go.
Exactly.
Excellent, thank you. I think we've got time just for another couple of questions. I appreciate we're over time. This is an interesting question because it's in with regards to the JCIH recommendations from 2019 that suggests that you should rescreen with OAE and not repeat AABR in the well baby nursery, given the low incidence of ANSD. What's your thoughts on that?
I am very aware that that is the instruction in many countries. I would personally say I would like all these children to be, when they are already at the stage of going to the audiological follow-up, I think that that would be a good idea. In some cases, for example, people have come to me in all sorts of different contexts and say it's very difficult to get the ABR done, especially when, for example, children are a little bit older and you really need to get them to sleep, and it's not very easy to get the toddler to sleep. And then I always say, like a sort of a bit of a cheat option is to do reflexes, because these, if a child has absolutely normal reflexes, the likelihood of them having an ANSD is very low. So if you are in a situation, and again, I'm very aware that not everybody has an ideal setup, so I want to be very down to earth with my sort of recommendations, is if you are in a position where you can't easily do an ABR, but you have a feeling that for example, you have a child or a little bit older child where the pure tone audiogram and their speech perception are very sort of mismatched, I would always say do reflexes. And if there is a problem with reflexes, then that gives you another piece of information to say, well, we really need to do an ABR.
Yeah, excellent, thank you. Miguel, one final question from your side, please.
Talk about if we should eliminate OAE testing during newborn screening and only use ABR, and if we only use ABR, should we be testing at low thresholds, for example at 15 dB NHL?
Okay, so that is a question that, you know, was a sort of core question of this whole talk in the first place. Should we all go and change to ABR? If you are filthy rich, then absolutely. Well, actually, no, I take that back. Without joking now, the thing is that, as you saw from one of the slides, that the cost effectiveness is quite different. It is much more expensive to find a case, any case, ANSD, typical sensorineural hearing loss, when we use ABR. The equipment is a little bit more expensive, but more importantly, it is more time consuming, and it is the workforce costs are the most important ones. And what was really interesting, that the example that I showed you was from Albania. Albania, the workforce costs aren't crazy there. They are pretty reasonable, but nevertheless the costs were still quite a bit higher. So cost is one thing, and I'm not saying cost should be the only thing that guides us. I think that it is up to your country, region, hospital to make this decision. The other thing that we should think about is that in some cases, depending on what kind of equipment you use, what is your screening protocol, that we could actually miss some milder cases with certain automated ABR protocols. But that is, I think, again, something that you can work with your sort of equipment providers, and that is not the reason to just say, oh, this won't work. So I know that it is extremely unsatisfying, because it would be really good if I would say yes, no, and that's the end of the story. I'm not going to do that, mainly because that is, I really, I am evidence-based. So I would say, if you can afford it, go for it, but also think about the potential disadvantages. The whole thing may take longer, so you may lose some people to follow-up or coverage or whatever. So never just look at, oh, I'm going to simply try to get all the ANSD cases. You also want all cases. You are not going for these few ANSD, and I'm so interested in ANSD. I think it's the most important and interesting condition in the world. But even I would say that you can't just sort of only try to get those and actually lose more children for all sorts of other things. So see a bigger picture. That's my only message, to be honest. And come back to the cost effectiveness analysis, because these things change all the time.
Absolutely, and I think that's what makes hearing screening around the world, people are using different protocols for different reasons. I work with some countries where they have a very early discharge and a high loss to follow-up, and they choose to do AABR for that reason, that the kids are screened really early and they will never get them back again.
Yeah, and if I may, because that is really important, because actually my PhD was about the very early otoacoustic emissions, which is actually a big question mark, because there are all sorts of physiological changes that happen in a baby a few hours after birth, and they may be due to oxygenation changes. They may be due to the fact that the baby's kidneys start to work, and actually a baby loses like 10% of their birth weight right after that, and that can actually affect the inner ear. And then it also can be due to the normal physiological stress of the whole labor. So and then there may be all sorts of muck in the ear canal. So otoacoustic emissions aren't without their own problems, even just without ANSD issues. So always see the bigger picture. That's my my overall conclusion.
And I think that's a wonderful point to end on. Thank you so
Absolutely.
much.
And it has been really fun. It has been really fun. Thank you so much for inviting me.
Excellent. We really do want to thank you, Dr. Uz, for such an excellent presentation, and again for sharing your expertise. Thank you everybody for your participation, and this is going to end our meeting for today.
Thank you.
Thank you.
Bye.
Bye. Bye.